Assalamu alaikum wa rahmatullahi wa barakatuh. It's indeed a pleasure and a privilege to be here at this meeting. And I'd like to start by thanking my dear friend and Chair of Surgery at the Prince Sultan Cardiac Center, Dr. Khalid Al-Khamis, his wonderful team, and of course the Saudi Heart Association for their kind invitation. So my talk is about surgical revascularization of the heart in patients with advanced heart failure. A patient with advanced heart failure can be treated like any other patient really, with medication, which might in some cases be the sole therapy we can offer these patients, with stents, and in the coming slide, I'll say a word about that. And of course, with heart transplantation, which is the way we would treat any severe form of advanced heart failure. But the real difference is here, and this is indeed the subject of my talk, the role of coronary artery bypass surgery to treat these patients. And I'm sure this esteemed audience knows better. More than half of patients with advanced heart failure have as a principal and primary pathology ischemic cardiomyopathy. So ischemic cardiomyopathy is the first cause of heart failure. Now a word about PCI. I'm sure the interventional cardiologists here would agree with me. The problem of PCI in patients with advanced heart failure is that it's challenging. It's challenging because you would need multiple stents, that there are bifurcation lesions, there's multiple CTOs, chronic total occlusions, and this makes it difficult and complex. And this is indeed within that context of patients who have poor LV function and therefore might need some form of MCS throughout the revascularization procedure. Which brings us to the pros and cons. So while PCI is minimally invasive, it's a small hole in the radial artery, the question really is, despite this minimally invasive nature of it, is revascularization complete? Is it feasible? Is it doable in this context? CABG, on the other hand, is of course much more invasive. There's an initial perioperative mortality that's quite high, and this ICO mortality or periprocedural mortality and morbidity is quite important to take into consideration. So the question I'm going to try to answer today is, if you have a patient with advanced heart failure and severe coronary artery disease, what would be your best option? Well, let's look at the data. Now, these studies, the VA studies and the CAS studies, were all analyzed in a meta-analysis done by Yusuf in 2004. And this is the result of, this is his meta-analysis from more than 2,000 patients between 1972 and 1984. Now, even at that time, you can see there seems to be an improvement in survival at 5 years and at 10 years with surgical revascularization. But you would all agree with me saying that, one, none of these studies really looked at advanced heart failure patients. In fact, only 10-20% had impaired LV function. And the techniques were ancient. 10% of the conduits were arterial. And also, of course, the medical therapy here was very old. So this is ancient data. We can almost forget it. Now, if you were to jump 10 years, and this is a very interesting study from Canada, from Alberta, 4,200 patients with heart failure were referred for angiography. 2,500 underwent revascularization, and the remaining group had medical therapy. And what this study has shown is that revascularization, whether with CABG or PCI, had an improved survival, as you can see here. This is a revascularization group. But when divided into the two forms of revascularization, CABG, surgical revascularization, does seem to have a slight better outcome as compared to PCI. Nevertheless, this signal favoring CABG is still, I suppose, limited by the data and the fact that there has been significant improvements both in the medical management of heart failure, but also in PCI and surgery. So what about more recent studies? And you can see here Syntax, Freedom, and Barry 2D studies. Now, none of these studies included patients with impaired LV function, and you can see only a very small proportion of patients had an ejection fraction less than 30 or 40 in these studies. The only randomized control trial that compared surgery to optimal medical therapy in patients with advanced heart failure is this one. It's, of course, the STICH trial. Now, the inclusion criteria was that the ejection fraction was to be less than 35%, and that the symptoms were predominantly those of heart failure, not of angina. And of course, we now know that the 10-year data of the STICH trial has been published, and it's called STICHES. So it's STICH-ES, STICH with extended survival. Now, this is the all-cause mortality 10 years follow-up of surgery versus CABG in the STICHES trial. So STICH plus extended survival. And what really is impressive is the necessary number to treat to show a survival benefit. Now, the number here, when you compare medical therapy versus CABG, is 14. So you need to operate on 14 patients with advanced heart failure to see a survival improvement. That same number for statins is 220. So 220 patients need statins to show a survival benefit. 14 patients need to have a bypass procedure to show a survival benefit. This is for all-cause mortality. And it's even more impressive for cardiovascular mortality, where the necessary number to treat to show a survival benefit is 11. And you can see here very early on, there's a significant improvement in mortality or a reduction in mortality with CABG as opposed to medical therapy. I would like to bring your attention to the early postoperative period, and you can see the lines cross on immediately at the postoperative period. And that's because, obviously, when you look at surgery being a more invasive therapy, there is an early perioperative mortality that affects outcomes. Surgery is an invasive procedure, it's done in high-risk patients. So in the initial postoperative period here, you can see there's a higher mortality in the surgical group as opposed to PCI. But that's understandable. PCI is a minimally invasive procedure, surgery is a maximally invasive procedure. But after that timeline, after the immediate post or perioperative period, the survival benefit is for surgery all the way. So the recommendations from STICH was that the more severe the coronary, the more severe the disease, so the lower the ejection fraction, the bigger the size of the heart, the more diffused coronary artery disease, the greater the benefit surgery had. Patients with other comorbidities, namely diabetes, this is again a factor that increases death in this group. Diabetic patients did better with surgery than on medical therapy. And the fact that you had angina or you didn't make a difference. Your survival benefit was assured. What about age? Now, I think this is really the message out of STICH, because the survival benefit in cardiovascular survival was consistent across all ages. Of course, the older the patient was, the lesser that survival benefit was clear. But then again, there were very few true elderly patients, and you can see only 6% of patients were above 75 years of age, and only 1% were octogenarians. But look at this curve. Now, this curve shows the advantage of the reduction in mortality according to age. And you can see here the hazard ratio is more than 25%. There is a more than 25% reduction in mortality in young patients having CABG who have advanced heart failure. And of course, with age, that number tends to come down. Now, the question I think that everybody will ask, cardiologists, surgeons, and intensivists, is what is the role of viability? Can we, surgeons, or can you, cardiologists, can you tell us that before we go to surgery, that this revascularization is going to make a difference, or are we just pouring water into sand? Well, STICH didn't really answer that. One, because viability assessment was not mandatory, and only half of the patients really had one. Two, you could do any form of viability assessment you wanted. You could have SPECT, or you could do dopamine stress echo to assess viability. And in fact, it wasn't even an inclusion criteria. And their conclusion was that viability didn't necessarily predict outcomes. So whether you had viability or you didn't, in STICH, it wasn't so clear if that provided a survival benefit. The only study that looked into the assessment of viability as a predictor of survival is this meta-analysis that included 24 studies and more than 3,000 patients. And what it showed is this. If you had a viable myocardium here, and you underwent surgical revascularization or any form of revascularization, there's a considerable reduction in mortality, a huge reduction. While if you had no viability, if your heart was just scar tissue, then that improvement in survival, that reduction in death is much lower. The question really is, how do we assess viability? What is the best way to do it? And cardiac MRI is probably one of the best ways to do it. This is a very small study, I acknowledge that. But if on cardiac MRI, the myocardium is more than 4.5 millimeters, and it doesn't shine up with gadolinium, then the possibility of functional recovery is around 85%. And of course, the opposite is true. If you have no viable myocardium, then the chances of functional recovery are much lower. And because of that, the ESC heart failure guidelines that we discussed this morning gave assessment of viability a class 2B recommendation, albeit with a level B evidence. So what STICH told us was that in a young patient who has severe left ventricular dysfunction, the first thing you want to do is exclude ischemic cardiomyopathy. You want to make sure that these patients do not have a reversible cause for heart failure. And that, of course, is done by angiography. And therefore, once you do establish coronary artery disease, CABG would treat them, would cure them from heart failure without medical therapy, without stents, and certainly without transplantation. And this is a class 1 recommendation on the ESC guidelines. And because it comes from a randomized controlled trial, the level of evidence is a level of evidence A. And indeed, myocardial revascularization is absolutely recommended in patients with heart failure when there is established coronary artery disease. Now, this is all very well in patients with reduced ejection fraction, with HEF-REF, heart failure with reduced ejection fraction. But what about HEF-PEF, heart failure with preserved ejection fraction? And this is a very busy slide, but I really just want to say it's a brilliant study that was done in Sweden involving more than 40,000 patients. What they did was all the patients with heart failure in Sweden were assessed. So if they had no heart failure and had a preserved ejection fraction, they were considered the reference. And then they categorized patients into patients with heart failure and reduced ejection fraction, and then the HEF-PEF, the heart failure with preserved ejection fraction, and finally the HEF-REF, heart failure with reduced ejection fraction. And what the conclusions of this study, or this trial showed, was that if you had an impaired LV function, so if your ejection fraction was low, it meant one thing. It meant that your chances of coming out from theater, from an operation, are low. Ejection fraction gives you an immediate prognostic value. How easy or difficult is it going to be for you and your surgeon to get you through the operation? But it's the heart failure syndrome that really, really, really counts on a long-term basis. And you can see it's a much stronger predictor of survival than ejection fraction itself. So heart failure is a syndrome, and you can have a preserved. I know it's difficult. It was very difficult for me as a surgeon to understand the difference between preserved and reduced ejection fraction, but heart failure with preserved ejection fraction is still a major risk factor for survival. The study does have its limitations, and I was a bit disappointed to see that the number of arteriographs was barely 4% in this study. And indeed, when you do look at the use of both internal mammary arteries, which is the standard of care today, in this study from the Cleveland Clinic, there's an obvious improvement in survival in patients with and without LV dysfunction when both internal mammary arteries are used, as you can see here in this image. I've got 2 slides on acute heart failure and revascularization. The SHOCK trial looked at patients with a STEMI and cardiogenic shock, and they were revascularized and they were randomized to revascularization or medical management. And the bottom line really is the chances of survival are low either case, and you can see the mortality rate in either case is around 50%, but those who did have revascularization had a better 6 months survival. This, however, is not a trial that studied acute heart failure. This was a trial of cardiogenic shock. This is the evidence for patients with revascularization with acute decompensated heart failure without cardiogenic shock. It is a black hole. There is no evidence. So, in conclusion, if your patient is eligible for surgery, so if he's young and you think there's a potential risk of having an ischemic component, the first thing that you need to do is an angiogram. You need to exclude ischemic cardiomyopathy. And this is done by an angiography. PCI has no evidence. There are no randomized control trial to confirm PCI. That's only done in a current trial led in Glasgow called the REVIVE trial. We need further research to establish how to assess viability. And finally, these are tough patients. They are difficult patients. It really is a teamwork. It's a surgeon, an anaesthetist, and a cardiologist in a heart team to share experience and expertise in these interventions. Thank you very much for your attention.